But Will, I'm turning the show over to you.
Thanks, Anton. I was just told before I started speaking that I have to stand over here, which for those of you who know me well will be a challenge. Thank you again to Accenture and Baxter for sponsoring. It's makes me happy that my alma mater is one of the sponsors of the event. Because I'm delighted to be here today and to be here with Ed. And we're going to talk to you a little bit about virtualization and vHealth. I'm going to do a bit of an intro, and then Ed's going to take you through some of the history of OTN as an example. During that part, I'm going to turn my phone off. Then we're going to talk about benefits to the health system performance. I'm going to turn it off now because it's giving me a Twitter feed on hashmark BWTC. Here, let me give you that. Then we're going to talk to you a little bit about benefits to health system performance, and we're going to go through some of the theoretical background around where OTN fits and virtualization, and then we're going to talk about the next generation and where pieces are going. Briefly, vHealth, virtual healthcare delivery, is any care process which is delivered remotely using information and communications technology, ICT. vHealth is different than eHealth or mHealth in that the care is actually delivered electronically. That can be as simple as a telephone call or as complex as telesurgery. But the process of virtualizing healthcare actually is disruptive, is what's called in the literature a disruptive innovation, and causes fundamental change in the way that the industry, our industry, is organized. So it turns out that good things do, in fact, grow in Ontario, and that we have been a leader in vHealth for a number of years. I'm not 100% sure why this has happened. It may be because of the geographic influences. It may be because we've had quite an innovative group of folks in and around Ontario. But for whatever reason, we have got companies, firms, hospitals that have grown up in Ontario as point solutions that have virtualized to date pharmacy, surgery, nursing, specialty consults, home care, and telepathology. Most recently, we of course have virtual ward, which sits in between and is virtualizing alternate levels of care in some interesting ways. Each of these companies or firms or hospitals has taken virtualization in a slice. The one I didn't put up here is DI PACS. DI PACS, of course, has virtualized radiology over the last decade, and it's pretty easy to understand how that's changed the industry when you look at that one. Telepathology at UHNGE is going to do the same thing, is doing the same thing for pathology, not just in Ontario, but also in Manitoba, Newfoundland, and soon globally. Similar system set up down in Pittsburgh is in competition. We're going to see big hubs like that. Over at St. Joe's and London Health Sciences, CSII, the Centre for Surgical Innovation, and CMAS, and there's a couple of other groups in there, are doing telesurgery and telementoring for surgery. They've got a commercial set of products coming out next year, which will allow hundreds of remote surgeries, the virtualization of surgery. PharmaTrust and the virtualization of pharmacy care, 15 installs at this point with big plans in the UK for their first site, and in the US is virtualizing pharmacy. And most of the people in this room would know that we changed the pharmacy regs last year to allow virtual pharmacists. Again, I'll leave it at that on the overall piece, just to say that each of these are point solutions at the beginning of an S-curve that's quite dramatic. And those of us who've been talking about this think that we're looking at about 25% of care by the end of the decade. Now I'm going to turn it over to my friend Ed Brown, who's going to take you really in depth on the OTN example, and then we'll come back and talk a little bit about the theory in the industry. Ed, over to you.
Thanks, Will. Hi, everybody. I came a little late today. I almost missed this event because I was looking for Muammar Gaddafi. Nobody told me that they already caught him this morning. I don't know if you heard that. No, that's what happens when you come late. You get to hear the news. But actually, the reason I'm late is I went to the Medical Sciences building where I graduated 25 years ago. And I was glad this talk isn't there because I got really anxious when I walked in there, like I didn't study for an exam or something. But it's great to be here. I see a lot of my friends out there. Of course, most of you are people that try to sell me stuff, and that probably explains the friendship. I also have a couple board members here, so I have to actually tell the truth, which is hard for me sometimes. But we have an enormous province, and that if you look at the source of virtual healthcare in Ontario, well, there's kind of where it all started. There's a lot more these days, but right now, in the beginning, it was all about size. So for those of you who aren't familiar with this province, it is 1 million square kilometers in size. And the top part, you could handily fit France in there. When I talk to Americans, I tell them that Ontario is exactly the size of California plus Texas plus Maryland, right? And I also tell them that about 12 million of our 13 million population lives in that little southern part near them. And of course, I tell them that's because we love them. We want to be close. But this sort of is really how virtual health in the telemedicine space all kind of started. So if you skip to OTN a bunch of years later, we think that we're the largest telemedicine network in the world. We have over 1,300 sites, 2,400 systems across the province. We are actually funded through the Government of Ontario. We benefit from funding from Canada Health Infoway, which has really helped accelerate our growth. We work a lot with eHealth Ontario, with Kiiwetinoong Okimakanik Northern Chiefs. And of course, we have a lot of members and partners all over the province, organizations that work with us to deliver their telemedicine. The vision is, I would say, embarrassingly simple, which is essentially that telemedicine should just be part of everyday care. People shouldn't have to think about it. They just use it. It's a no-brainer. It's simple. It's easy. If you're a patient, do you always have to go sit in the doctor's waiting room? Do you have to read the 5-year-old magazines and catch the bugs, for the person beside you? Or can you do some of your visits remotely through video conferencing from the comfort of your office or home? So simple things like that seem kind of obvious, and they will be, I think, in retrospect when we have that actually happening. Of course, we don't have it happening yet. We still have a ton of work to do. And what OTN is doing is really trying to be a catalyst for a lot of that growth in Ontario. We deliver our care right now through these 5 programs or services. We call them channels. Number 1 is clinical telemedicine, which is live video conferencing, usually a doctor, other health professional, patient at the other end. We have emergency care. We have a lot of education happening. We have something called Store Forward, and very exciting, the new frontier is telehome care. I'm going to just sort of drill a little bit into each of these. By the way, stop me and heckle if I'm not clear, if you have a question. Do you have a question? You're just coughing. Okay. Yeah, you okay? So there's a lot of organizations participating. So like 6 years ago, we had all the hospitals in the province already kind of wired up, so we needed something else to do. So we went out across the community and tried to get all kinds of folks hooked in. And as of today, there's something like 85 or 90 family health teams. There's 350 mental health agencies. There's a bunch of prisons. CCACs are users, a lot of specialist offices, and the list goes on. So it's really taken off, and we're growing very quickly. At any given moment, we have about 300 new organizations that we're working to develop to put on the network. So we're growing quite aggressively in that space. And of course, this is the video piece. By the way, this slide is so old. You see what's old about this slide? When's the last time you saw a monitor that looked like that? And I keep thinking about deleting this, but I leave it in not because it has great emotional attachment for me, but because the message here is that it's not really about the technology, right? We didn't invent anything. We didn't invent video conferencing. The secret to what I think is the growth in Ontario is that we're focused on making this practical, on making this useful, on making the various technologies come together seamlessly so that people, providers can work with patients, work with each other more effectively, and that's the focus here. Also, this is a little weird because look at where that stethoscope is. probably should put it under the clothes. We call that the orthopedic point, right there. And also, I don't think patients should really be sitting on nurses' laps, but that's another story. Last year we had about 135,000 patient consultations across this network, and we're actually growing at 30% right now. So the growth continues quite aggressively. Education, 12,000 education events. There's actually about 5 or 6 created every single hour of every day. These are the specialties, so there's a whole whack of them. The kicker is the bottom, which says 30 others, so almost any specialty can use telemedicine. It just so happens that mental health is actually the biggest one, so about 50% of our activity is actually mental health. And there's what it is. What about the patients? Where do they go? So about half of them go to the hospital in order to see their remote provider, and about half of them actually are in community settings. That actually was a big goal for us. We wanted to get people out of the hospital into the community, and last year was the first year that more were seen in the community. The patient part of this is a no-brainer. Patients love this. We basically stopped doing surveys so often because we always got straight A's from patients, 97% sort of thing. But they also see a lot of other benefits. They see their providers quicker, they feel there's more regular follow-up, and they actually feel like their healthcare providers are working as a team, which is probably not true, but they do believe that their healthcare providers are working as a team, which is great. And this is my favorite slide. Anybody here from the Government of Ontario? Beautiful. Okay, watch this slide, because there's a program called Northern Health Travel Grants that actually subsidizes patients in the north that have to travel. And these numbers here represent what the Northern Health Travel Grants program might have paid had all the patients that used telemedicine actually traveled. So when we calculate that out, last year we actually avoided $25 million in Northern Health Travel Grants payments. And since our base budget is only $22.5 million, you think, like, are we a profit center for government? Are we making money for you? As a taxpayer, so I think that's pretty good. Just on this one stat, we can almost justify all the energy that we put into this. It's also very green, as you can see. We saved about 16 million kilograms of carbon burning by avoiding travel last year. This is a pretty new feature for us, Telemedicine Directory. We have 100 and something health providers who are offering their services by telemedicine. If you want to find a psychiatrist in Upper Rubber Boot, you can search for that, and it'll pop up, and it'll be a profile that'll tell you, how that psychiatrist accepts patients. And you can look at our website and have a tour through this if you're interested. We also are supporting a lot of emergency services. There's some very exciting ones. Telestroke has been around for about 8 or 9 years now. There's a brand new trauma program. St. Mike's and Sunnybrook have combined forces and launched a new trauma program in October. They've already seen 4 patients. Very exciting. Education, as I said, is huge. Is there internet access here, by the way? Yes. If I click on this, do I get on? Okay, let me try that. That worked. So this is our new learning center. This is pretty fresh. If you want to find out what's happening, just go out and go onto the web to our learning.otn.ca. And these are all the events happening today. So there's some stuff happening Thursday. Let's see if there's anything interesting here. Pediatric obstetrics, that's interesting. So you can see there's a whole bunch of events today on the 20th, 21st these are publicly available events. So these are events where the actual people that have put these on have said anybody can come. They post it, you can go on here, click on it, and you can join this event if you want to. There's information, there's PowerPoints or whatever else is in there that they want to share with you. So very, very simple to find education. You can also put a keyword search in, so if you're interested in cardiology, you'll get an email every time somebody posts a cardiology event. Close my window, he says. Okay. Oops, closed the wrong thing. Technical support.
Push the orange bar.
Wow. Okay. Great. We have a webcasting center. There's about 1,000 webcasts on there if you want to have a look. Okay, this is the Store Forward channel. Anybody not know what Store Forward is? Don't be shy. Okay, this is for you and you. So this is asynchronous telemedicine. You can take a picture of somebody's funny rash, add a bunch of medical information from your electronic record or type it in, and then send that off to a dermatologist. And they come back with a diagnosis. This is working really well in dermatology. We're using it for retinal screening as well. In dermatology, they're actually reducing the waiting time for your diagnosis from 6 months or more for a face-to-face visit to 6 days. So that's very exciting. In ophthalmology, the ophthalmologists are telling us that they're able to see a lot more patients this way. They can see something like 10 in 40 minutes instead of the usual 10 in 2 hours. So if you start to think about that and how that projects across efficiency, you can see that there's some great efficiencies to be gained. And that's what Store Forward looks like. Okay, so this is the teleophthalmology and the retinal screening and what that looks like. This is really an important area for diabetics. You're probably aware that we have about over 900,000 diabetics in Ontario, and a third of them actually don't get retinal screening. Diabetes is the #1 cause of blindness in Canada. So we would like to find those 300,000 diabetics and make sure they get proper screening. And finally, this is the last and the new frontier, telehome care. This is actually all about chronic disease management. So what we're doing is really a combination of nurse coaching with remote monitoring technology. The really important part is the coaching, because what is happening here is that patients are being educated and empowered to set their own goals, to come up with their own strategies to avoid getting sicker and to stay well. And that's turned out to be a very positive and powerful combination. Here's an example of some of the technology that we're using out there. There's blood pressure cuffs and other little things that go into people's homes. We actually studied this way back when. This was a project funded through Infoway and the Ministry of Health about 3 or 4 years ago now, with 800 patients with heart failure and chronic lung disease. And these numbers kind of blew me away. Price Waterhouse did this evaluation for us, so I didn't make it up. But they found that about 65% reduction in hospitalization for these patients. So unbelievable, 70% reduction in emerge visits. Very, very powerful. And this is just really by helping patients understand how to stay well and how to stay out of hospital. By the way, there's a little financial thing at the bottom for those who count money. Every dollar that you would have invested in this program, not the startups cost a little more, but on an ongoing basis, every dollar invested would avoid $5 in hospitalization costs. So very, very powerful investment. That's important because 1% of Ontario's population actually spends about 50% of our healthcare system budget, right? So that's 130,000 people who account for about $23 billion last year, okay? That's almost enough to like hire a doctor and put the doctor in everybody's basement. So those are the people we want to find, and with interventions like this, and by the way, that 1% seems to overlap pretty nicely with the population that we want to use telehome care with. So we want to get those people hooked up, get them a coach, and keep those people happy and healthy and out of the hospital. That's a win-win. Somebody once asked me what OTN does, and I couldn't remember, so I wrote it down on this slide. But it's actually pretty simple. We create really a governance structure, so everybody can kind of sign up. It's easy to become a member. You just kind of sign a contract, follow the rules of the road, which are technical, security, privacy, how to respect other members, not to sort of call their studios or surf for naked people in emerged apartments or whatever. And that's how you join the network and become part of a large collaborative group. Then we provide some services to support that, scheduling and technical support, training, things like that. And then we work very hard out there in the field to work with providers, with organizations, to just have them understand how to use this and try to get them started on using it. So we're very aggressive in terms of our adoption work. And this helps. We have, this is our self-scheduling software. So there's a couple thousand users out there who schedule with each other using this technology over the internet. But of course, at the end of the day, the key piece is the providers and their innovation and their interest, and they're our champions. And of course, we urge them to use their powers for good and not evil, of course. So I think this is my last slide, but if you take a look at what we've got there, remember that map of Ontario? Well, that was about rural access, and that still is very central to our success. But you can see we're kind of building down from the top of this pyramid. We started out with that rural access piece, access to over great distances, better access to care because there's maldistribution of providers even in cities. And then looking at urgent care, things like telestroke and trauma that you simply would not get without telemedicine, down to increased efficiency of providers, the dermatologists, the ophthalmologists, seeing patients better, faster, quicker, and of course, chronic disease management, really helping to transform our healthcare system to where we want to go next. And I think that's where I hand it over to Will, who will tell us where we want to go next.
What's going on here? Where are we, and how do we think about the kind of change? I think the folks in this room will appreciate how important the change that OTN has catalyzed is and how important it will be. You can see very quickly that if we push this, the benefits to first to the 1% and then to all of society will be huge as we move this out. How many folks in the room are familiar with Clay Christensen and his co-authors' works? Okay, so what I'm going to do here is this is one case study. And I have to be back here or someone's going to get angry at me. This is one case study, but what we will do at Mowat Center next week is we will release our report, Shifting Gears Health, in which we'll talk about 5 case studies in the V-Health space and talk about this as a trend. Because while Ed has focused and OTN has focused on the pieces that he's discussed, there are also people doing this in pharmacy, surgery, and other areas. And so it's important for us to have a framework and a mental model for the change that's going on here. Because folks, this change is every bit as big this decade as the move to ambulatory care was in the 90s. And we have to figure out not just how we're going to grow V-Health, but also, as they had to figure out in the 90s, how we're going to shrink the other parts of the system and move resources. Because as anyone who's worked in healthcare in Ontario knows, the trick is moving resources. So let's get a mental model going here on what's going using the Christensen work. A disruptive technology starts with a sophisticated technology that simplifies a process. It usually focuses on a marginal or marginalized group. So as in this case, with northern and remote and rural, we had a marginalized group, a low-cost, innovative business model that turns into an economically coherent value network. Here's a chart that kind of shows this using a cost piece and a performance piece. And the idea here is that the green line is the disruptive technology. It comes in and develops value until it reaches a point of maturity where it can compete with the existing technology. So the example Clay Christensen uses is the PC competing against the microcomputer. When the PC first emerged, it was a joke relative to the microcomputer. It was kids using Apple IICs, but of course the microcomputer does not exist anymore as a commercial, well, I'm overstating that when I say it that way, but the PC is the dominant technology at this point. What has happened here is, again, a new entrant has come in. The new entrant is not just in the spaces that Ed talked about, but in other ones, and is building forward and will eventually displace large parts of the existing technology. To start with, it's not as good, but it's good enough. So what did you call it? Upper rubber boot? Yeah, in upper rubber boot, originally, this was not the same as having a nurse or a doctor there, but it was good enough. And the good enough piece gets you in the door to expand it. When you unpack this, there's really 3 types of business models that are being pushed here. There are solution shops, there are value-added processes, and there are facilitated user networks. I think everyone can probably see immediately how a facilitated user network is being constructed here, how the technology is being used to do that. But let me just talk about how this is a VAP as well, the value-added process. Store forward. When you do asynchronous treatment for retinal or dermatology, you change the business model fundamentally in some really profound ways. By taking the treatment and making it asynchronous, meaning that the patient and provider don't have to be in the same place at the same time, you allow the volumes to be moved among specialists, so the optometrist can be put in front of the ophthalmologist for the 6 out of 10 retinal scans that Ed tells me can be read that way. You can stack and rack them so that you can organize a provider day better. You can, if you want to get aggressive, as they are with DI now in Norway, You can, in Scandinavia, you can create an auction method and go to the lowest cost, highest quality provider and start auctioning who does the reads at what time. There's a whole bunch of value chain things that you can do once you've virtualized and created an asynchronous environment. Solution shops, again, take a look at Shelburne and what's happened to the old Shelburne Headwaters Hospital. They've now got 3 OTN rooms, and it's now a medical office building, but they're bringing the best care in Ontario to Shelburne, right? It's my local community. I mean, Shelburne, Ontario has the best specialists virtually. The solution shop pieces are there and going. Here's a brainstorm list that Ed and I did the other day on where the value may be. And it's just a checklist here you can go through, right? Reduced travel wait times, elimination of politeness time, right? You have to be polite to someone who travels 200 miles for a retinal scan. But if you just send the image, you don't have to be polite. So it's 40 minutes instead of 2 hours. Ability to aggregate volumes, right? We know higher volumes, better quality, right? Look at telepathology. What woman living in Corner Brook wants the local pathologist doing her breast cancer pathology? No one. You want the best guys at UHN doing it, and you want the second best guy checking it. Excuse me. Ability to substitute lower cost care providers. That's the optometrist, ophthalmologist example. The ability to aggregate, industrialize, use manufacturing, QIA techniques, which many people in this room know about. Auction pricing mechanisms, lower infection rates. What the heck are we thinking? Bringing sick kids into pediatric waiting rooms if we could do the diagnosis virtually and not expose them. Why would we not do that? Why would, from an infection control point of view, if we could do the diagnosis remotely, why would it not be better to do the thing remotely? And then finally, the avoidance of greenhouse gases. I mean, this is almost as good as local LCBO stores in terms of avoiding greenhouse gases. We do not want people and then finally, it's not on this list. I don't know why it's not on this list. But you know, the other thing you can do here that a bunch of these guys are doing is you can go international, right? The only barriers are regulatory. And those are good, clean knowledge economy jobs right here in Ontario. That good, clean knowledge economy jobs are important, as anyone in government knows. So we can look at that and really think about that. This could be an economic driver for us in the long term, bringing the best medicine not just to all of Canada, but of all of the world. Now I'm going to turn it back to Ed, who's going to go to, nope, I'm not. I'm going to just say a couple more things on accelerating V-Health. There's 5 or 6 things we can do here. We can identify and support the early organizations. We can get the physical out of the fee schedule. Government needs a process to go through all of its regs and get the implicit assumption of physicality out of the funding formulas. Ambulatory care centers, physician fee schedules, everything. We got to get the physical out of the schedules. We got to remove geographic assumptions from regulations. We've started doing that with the pharmacy regs. We need to support internationalization of credentials, move to an Ontario standard for credentials that's recognized worldwide, and we need to fund virtual patient navigation systems. Eventually, we need to encourage price competition amongst Canadian virtual diagnostics and mature V-Health providers so that we get a price competition or price advantage against the rest of the world. We are in competition with Pittsburgh for telepathology. We will be in competition with a whole bunch of centers. This is going to be a growing industry, and we need to have a price advantage here, and that means getting volume and getting volume early. Ed, I'm going to turn back to you for the final piece.
Thanks, Will. I think there's only one thing you're going to remember about this presentation. That's that Will and Ed recommend eliminating politeness. So that's what you said, isn't it? Yeah. Okay. Okay. So I'm going to test this. We're kind of updating our vision and strategy, so I'm going to test it on you. You're actually a guinea pig audience, so any feedback you have would be appreciated. But at the end of the day, what we're really trying to do, and it's not, we're the facilitator, but it's our partners out there that are creative in the healthcare system. We're trying to really create a healthcare system with faster access, better integrated quality care, and lower cost service delivery. That's really what it's all about. And I think, I believe that virtual healthcare is fundamental to transforming our bricks and mortar healthcare system. We're not going to get anywhere unless we figure out how to do that. And how we've lately kind of structured this is really to try to make this really simple to understand for folks. So there's a virtual healthcare office, right? Everything you need to do around primary care. So that includes how you reach out to your patients, how you bring specialists in, how you connect with people in the community that are working around patient care. Number two is a virtual hospital, so the emergency stuff. This is kind of different, requires kind of a different structure, needs to be faster, needs to be platinum service, it's always got to work. That's a bit of a different system. How do you get people on call? How do you make sure they're always there and available when you need them? And Telestroke, of course, is our model for that, where we have 24/7 neurologists who are taking call right now for strokes anywhere in the province. And the third one is around chronic disease, right? That's the big challenge for our healthcare systems as we move forward. How do we take care, how do we get patients to take care of themselves in a better way? And so looking at how to use virtual technologies in that space is kind of central issue 3. So this is what we're doing. This is the focus of all of the virtual care that we're looking at. Here's a theme. I'm going to test it on you. Test audience. Okay. Whoa, that wasn't good. So really what we're trying to do is, in a way, reinvent healthcare. We want to unleash the power of telemedicine for a better healthcare experience. So the concept is there's something there. You can see the power. We have to figure out how to let it out and let it be successful in Ontario. And our strategic plan, again, is very, very simple. In fact, there's only 2 things we have to do. It's very easy over the next 5 years. All we want to do is galvanize the healthcare system to accelerate telemedicine adoption. That means reaching out at different levels and getting people to adopt this and make it their own. There's really 3 parts to that. One is the people that plan stuff, the people that run the system. That's probably most of you. So having you understand that this can be a powerful addition to whatever you're doing. And of course, the changes we have to make to address that. Brokering, so adoption and brokering, that's actually like matchmaking. We're a dating service. We're helping people to find each other, giving them ways to organize their care together. And that's really important. That'll include things like enabling consultants to publish and advertise their clinics, having professional networking so people connect, the telemedicine directory that you just saw a little earlier so you can find the resources that you need. And of course, governance is very important. I told you, what our approach is to governance. That's actually kind of threatened right now because there's a lot of new technology. You can use your iPhone to do a lot of stuff, and that's great. But the issue is, how do we maintain this as a system so people still can work with their partners? And that's one of our challenges. Okay, so that's strategy 1. Galvanize you to get out there and integrate telemedicine. Strategy 2 is to make it cheaper, faster, and better. So we know we have to lower the cost. Somebody just clap for that. We have to lower the cost, and we have to make it simple. Anything that's going to work in technology basically needs to be simple. It doesn't matter how much you like the flashing lights and the funny code. In healthcare in particular, if they have to think, if you have to train a doctor on something, forget about it. It ain't going to happen. They got to turn it on, and it's got to just kind of be obvious how this works. So we have to really get to that point, and we're not even close, to tell you the truth. We have a long way to go to make this easier and cheaper. And so our strategy is going to be to work on a telemedicine center, which is really going to be an aggregate of these technologies in one place with one password, very simple to use. Telehome care for us, creating a utility that everybody can use that makes it easy for people to do. We're already, by the way, happily doing that. I didn't really mention it, but we're working on a program right now with 3 LHINs to grow telehome care across the province. And Learning Center, you saw that. That's pretty fundamental. Learning to me is about dissemination of best practices. It's about quality, right? It's about creating relationships. So it's a very, very important part of a quality and integrated healthcare system. So that's our strategy. It's really simple. And this is the sort of thing we're doing. So this isn't operational yet. We can do stuff on the iPad, but we haven't released it. But this is what you'll be doing pretty soon in the province. You'll pick up your iPad, see the patient emerge, look at the X-ray, have all the data, make your diagnosis, and go back to bed. So this is kind of where the world's going. Store forward too. You'll be able to see that ugly mole. I don't know, is that cancer or not, dermatologist? Yeah, cancer? No, ugly mole. Anyway, you'll be able to do this stuff very simply with your iPad. So what are the benefits of this? And I think, I don't want to repeat what Will said, but this is about changing the locus of care to the patients. We always forget about the patient. This is so patient-focused. They get it. They get that they're getting better service. This is about enabling those multidisciplinary teams to work together. It's about the lower cost providers who are supported remotely by higher priced providers if they need them, but the lower cost providers can deliver a lot of that care. It's about applying AI. So actually we're not going to need providers for everything. I'm thinking about those retinal images, for example. There's technologies that actually can do a lot of that screening. Maybe we don't need not only the retinal specialist or the optometrist, maybe the machine will take a first pass at this. So looking at how we can leverage technology that way. Will talks about those solution shops. So those are the expert consultants. Well, we can make it better. We can bring the right people in the room to collaborate around care and really make them a lot more efficient. There's patients that bounce to 6 different specialists. The family doc gets a letter from every one of them. The letters say totally different things about what to do with that patient. What if you could just put them in the room together for 20 minutes just to figure out what to do with that patient? That would save us a lot of money, and that's what's called customer service right there. What about value-added processes? So the other side of this is, what about things where you don't have to think, right? We know diabetics need these 3 things, and they're going to be healthier and live longer. We also know that they only get 50% of those 3 things. That's crazy. We know exactly what quality means. How do we implement that? Well, that's like manufacturing, right? We have to actually figure out how to do it every time with every diabetic. And these are the technologies that are going to support that kind of process as well, right? That's the opposite of the solution shop, the thinking, the guessing, the intellectual part of healthcare. That's the manufacturing side, and the technology will support implementation of those processes around the patient in the community. So that's where we are. I don't know, I have some fun thinking about what the world will look like in 5 years. These are random educated guesses, but it looks like there should be at least 1 million physician visits by 2015 done virtually. There's 70 million physician visits a year in Ontario. I think we should be able to get at least 2% or 3% of them. We think there'll be 40,000 telehome care patients. We're going to free up hospital beds, avoid a bunch of money for Northern Health travel grants and a lot of travel, reduce emergency department visits, reduce some wait times for some specialists, avoid critical care transfers where appropriate. I think we could reduce nursing home admissions. Those are numbers from the VA around telehome care. I think we could avoid visual impairment, better productivity for many specialists. We're going to actually save lives. Telestroke should save about 68 a year if we have it fully implemented. And then there's a whole bunch of things that are a little less tangible right now, but will become very real. Things like better knowledge and mentoring, better collaboration, and really the transformative piece of this technology. I don't know what that'll cost, but I've just called it priceless. Just like the MasterCard commercial. So I think this is my last slide. So you could help. There's some stuff here that you can help with. If you believe that we need to have a virtual healthcare system in Ontario, there's a lot of regulations out there. If I happen to work in the ministry, I'd probably just go through all the regulations we have and try to figure out which ones are actually slowing down or stopping virtual healthcare. It won't be a short list, actually. So it'd be great if somebody could take that on. We have some basic, some of the bigger problems are licensure. For example, when doctors in Ontario want to see patients in Nunavut, they usually have to get a Nunavut license, which they don't do. So it really impedes that kind of care over borders, credentialing across hospital facilities. We actually, doctors get paid for doing telemedicine right now in Ontario, but it's not an insured service. It gets paid from another pot. So, you kind of got to wonder, why isn't this an insured service? Why? I don't know. We should probably do something about that. I guess sorry?
There is an OHIP fee schedule for palliative medicine, telemedicine.
Beautiful.
Requires a 10-minute minimum.
Correct.
That's right. It requires a 10-minute minimum, which effectively wipes out the usefulness of it. So if you can accomplish a visit in under 10 minutes, you can't be paid for it. 6 pages of regs. It's great reading. I
Less
posted it.
efficient you are,
Yeah.
the more you
I
get
posted
paid.
it. I posted it as a joke on my LinkedIn website.
Okay. What if he took the politeness out of that? Nobody would get paid. But anyway, we also, I mean, this probably has nothing to do with telemedicine. You know, we're there to support this, but you know, we actually have divergent policies, right? We need to have policies that really encourage patient-centered care, and when people are driven to do things that way, they discover they actually need these technologies to do that properly, right? So that's really the story. So the story is, you know, we need to start moving away from pure paying for every service and looking at how we pay for quality, for outcomes, because that will encourage this kind of technology. Of course, we need to reward efficiency, maybe not politeness, and share risk as well. So those are policy issues, but I think when you start to think about the technology, it's a catalyst. You begin to see how you can use that technology to support these very important policies that are happening around the world. This is, by the way, happening everywhere. You know, the Accountable Care Organization movement in the US, this is what it's all about. So I hope we're walking down that road as well in Ontario. We need some investment. We have to make it easier. Unfortunately, making it cheaper actually costs money because we have to invest in the changes, the transformation to actually make it more ubiquitous, cheaper, and easier. So there's another plea. And my very last plea is to think right. So when you're thinking about any healthcare delivery, any planning that you're doing, spend 10 seconds just considering whether these technologies would provide support to your program. And that's a general question to everybody in the room. I think I'm done. I'm done.
Great challenge, Ed. Thank you. So save your questions for a moment, Ed. Can a patient sign up as simply as you suggested, find him or herself a physician, and be tied into care?
Absolutely not. That's not how it works here. We have a gatekeeper system here, right? So the concept is that you go to primary care. So you can find yourself a primary care provider of some type and sign up if you need specialized care, if you need telehome care, if you need whatever. That's sort of the gatekeeper.
Thank you. And then way at the other end, you work with a lot of suppliers. Can suppliers use OTN to in fact train and maintain the relationship with their customers?
Yeah, we have what we call a premium services program. So for non-members to use the system, they can do that. They simply have to call our toll-free number and find somebody willing to host them at the other end.
I got more questions, but anybody out here? Right here? Graham?
Yeah, first of all, thank you for a tremendous presentation, both of you. Very informative. I thought that the very last slide was probably the singular most important slide. You have studies, and you showed it on some of your slides, of the savings that are taking place. And at Canada Health InfoWay, as you know, we've done some studies that also show. But the big problem, which you began to underline on that last slide, was there's no alignment. And this is true right across the country. This is not an Ontario problem. We see it in every province. But for example, to use a local, we had an election campaign in which the government talked about negotiations with the doctors and getting money back from them. I think that misses the whole point that you're driving at. The issue isn't to get money back from the doctors. The issue is to provide the incentive to doctors and all other providers to more effectively use this system. Otherwise, it's going to start running into trouble. You've had tremendous success, you know, as you get to the first 30% or so, but to get beyond that, we get into culture change, and culture change requires incentive change. So I mean, I'd like to hear both your thoughts on how we get the message to government that this isn't so much about cutting back doctors' incomes or nurses' incomes or whatever. This has got more to do with shifting the incentives so that they can take advantage of this, and that kind of alignment in turn will provide us the kinds of things we need to get us out of our sustainability problems.
Yeah, well, of course, you're absolutely right. I think the issue is we're a bunch of people who, at our core, are providing technologies and encouraging people to use them. That's a little crazy when you think about it. because really people have goals and business needs and things they want to achieve, and then they make technology part of that plan. That's how most things in the world work. You want to sell shoes, and by the way, you need a cash register and a Visa swiping thing to do it. But you don't go into business saying, I want to swipe Visa cards, what should I sell? Right? It doesn't work that way. So we kind of are in this a little bit backwards when we're on the technology side. But I think the whole Western world recognizes exactly what you've said, that we do have to change the model. I'll go out on a limb here and tell you that I think most physicians out there realize that they're not practicing in an optimal system. They're very dedicated to their patients and improving care. And if models come that are that share the risk, that allow them to practice better medicine, they're going to jump on it as well. We have to build those partnerships. We've had a bit of trouble, I think, in this province with the partnership between the medical profession, perhaps, and government. I'd love to see that come together and be more productive. But I think, these are things we have to address. We cannot continue in the 1960s Medicare model and expect that we're going to be able to transform the system. My last point is that we're starting to work with 3 of the LHINs. Anybody from the LHINs here? Yeah, so we're working with 3 LHINs on telehome care, and what's really exciting for me is that people kind of see that this is transformational, and they're looking at how healthcare is delivered in their LHIN, and I think they're picking up that this is something that really can powerfully change the way chronic disease is managed in the community. So I think that's very exciting and very, very promising, and those folks have the ability, the capability, they're empowered to change the healthcare system in their LHIN, and so I think we may see some exciting stuff happening.
Just a couple of comments. Industrial transformation and the role that government plays changes over time. And as we enter the second decade of the InfoWay journey, we are actually entering a fundamentally different place, in part because of the great success that we've had in the first decade of InfoWay, both at the InfoWay level and on the ground. As we enter that second decade, the role of government changes. And government in a maturing industry now needs to step up and be very thoughtful about what the shape of the mature industry will be. Ed said quite rightly that one of those changes is that e-health was something that we did to paper processes. With DI PACS, it became part of and embedded in the process. You can see with V-Health and what Ed's talked about with OTN that that's going to happen for every care process, and it should. At this point in the journey, government needs a process to think about how to accelerate the change. I said in passing earlier, I made a reference to the hospital restructuring in Ontario. It's that kind of a change process, Graham, right? The same way that we grappled with the question of, okay, I know how to build an ambulatory center. I know that that's a good thing, but what the heck do I do to get those inpatient days back out, right? And we needed a process that thoughtfully did that. We now need a process to make virtualization happen. The one thing that we should do for sure is let doctors use the telephone, right? We spent $3.5 billion on 21st century technology, and we do not let doctors in this province use 19th century technology in the course of their daily business. That is flat out nuts, and it needs to stop, and it needs to stop in this fee negotiation. So, yeah.
We'll send this presentation to our new minister, Deb Matthews, who is familiar with this, no doubt, Ed. I'm sure she is. Ed, we also talked a little bit some time ago about the internationalization of this and relationships you may or may not have with India and the impact. You didn't address that. Are you that far, or are these things you're just thinking about?
Well, health providers around the province are actually doing lots of things internationally. That's been happening for quite a long time. Some of them are starting to use telemedicine. Almost every day, if you follow the press, there's a new bunch of clinics opening somewhere. I know UHN and Sick Kids are both connected with hospitals. I saw a demo 2 weeks ago between surgeons in London, Ontario, and a province in China. So Canada's reached out pretty much across the world already in healthcare. It's happening. The world's getting smaller.
We get time for one more. There we go.
And how would you look at balancing, I guess, the needs of your own province with those international markets that you would want to access? In Ontario, we have huge issues in terms of wait times, ALC, ER, et cetera. And I'm curious to know how you would look at balancing all of that, because obviously here we would be saying use the health resources that we have for our own folks first, right?
Well, I'm not really a politician, so I'm not going to be good at that. I know that's very controversial. But I think what I've heard is that, you know, a lot of the folks who are doing that in Ontario are organizing it really so that the revenue that they bring in is actually improving access and quality to healthcare in Ontario. So I think they're all very conscious of that, and the folks I've seen who are doing this are really careful to make sure that it's actually adding to our healthcare system and not subtracting. I know that seems, you know, when you look at that externally, it's not that clear, but I think they're pretty careful to do that.
Can I just add something on this one? There's a, what you're saying is an example of a lump of labor fallacy. The idea that the labor pool for a particular area is finite. In fact, what happens in expanding markets is that you shift the supply and more people will come into an area. Now, I recognize the need to protect Ontarians' interest and the political need further to do that. So I think that we need a practical standard to know that we're doing that. But I do think that it is a lump of labor fallacy, and I'm happy to defend that point of view. Okay, here's the practical way to do it. We have something in Ontario called a wait time standard. We have it for a bunch of things. We need a wait times plus standard. And we need to say to providers that you cannot provide international care unless you meet a wait times plus standard. So, to be specific, hips and knees, 20 weeks, 90% of patients. Let's set a wait times plus standard. 99% of patients, 10 weeks. If you do 99% of your patients in 10 weeks for hips and knees, we'll let you do out of LHIN volumes. When everyone in the province is at the wait times plus standard, we'll let you do out of province people. When everyone in the country is at that standard, we'll let you go international. But it's got to be Ontarians first. So create a standard, know that you're doing it, call it wait times plus, and do all the political stuff. But honestly, that's just cosmetics, because really, it's a lump of labor. It's like saying that when we recruit Filipino nurses, that Philippines runs out of nurses. Well, no, they don't. They end up educating 8 times as many nurses as they need for domestic demand, and they have more nurses in the Philippines than almost anywhere else in the world, and they now run the HMO call centers for the US because of nursing recruitment. So it's a lump of labor fallacy, but I'll still go for the cosmetic change.
So on behalf of Accenture and Baxter, I'd like to thank these two speakers, and we have a way yet of finding how much they appreciate. So I ask them to applaud. Let's see how loud it is. Not bad, Ed. Not bad, Ed. And thanks for bringing all the context to it, Will. Much appreciated. On December 1st, Jack Kitts is going to come over. Jack wants to talk about his quality program. He wants to be the best quality provider in the country, and he's going to tell us how he knows he'll be the best. He also, of course, chairs the Quality Council, and he's going to speak about that December 1st. Thank you for coming to breakfast with the Chiefs.